Alors, assurer une couverture
So, the theme of this plenary is how to improve the quality of health services, and we want to ensure universal healthcare coverage. We're going to talk about that this morning. But obviously, we've wanted to tackle the quality of health services and the availability of those quality services. And we are very fortunate to have three players that work at different levels, but according to me, they are quite complementary. I'm going to give them the floor so that they can, first of all, present what they do. Ladies first.
In a few words, what are the main goals of the government organization you work for? It's called MSH. Please take the
MSH has been
microphone.
I will talk from an experience of Rwanda, and MSH has been implementing a system strengthening approach in Rwanda for the last 8 years. And the health system strengthening aims at increasing coverage, but not only coverage, also the quality, access to quality services. And in so doing, we all know that the definition of quality has been a challenge to different countries, and Rwanda has managed to define, to have its own definition with regard to quality of services. And this was aimed at, of course, with different definitions to quality, you have diverse goals. So having a common definition has helped Rwanda to have a common goal towards improving quality of services in Rwanda. And this starts with defining quality services, the expected quality services at different levels of the health facilities, what we call the service packages, from high above, from the national referral hospitals to the lowest level of the community health workers. In that, further to that, we've gone further to really define quality by setting standards. We believe quality is standard driven, and defining quality of services based on the packages at different level has really helped Rwanda to increase access to health services at different levels of the health system.
So, Joy, if it's okay with you, we'll dig deeper into the actual definition of quality just a little bit later down the road. I wanted everybody to hear you and understand precisely from what point of view you're going to be speaking during this panel. Okay?
Thank you.
I'd like to hear from Christophe Paquet. Alors, vous intervenez à un niveau, on va dire.
So you intervene more at the macroeconomic level. You manage financial funds at the level of a French development agency with many financial means, and I would like you to give us some examples. Well, right, good morning. Thank you to the Pierre Fabre Foundation who've invited me to take part to that first roundtable. As you know, the French Development Agency is a government agency which implements the cooperation policy. It's also a development bank, and the umbrella of the foreign affairs, and also involving the overseas territories. We have a budget of 9 million euro per year, and mostly we provide loans to states, but also loans to the private sector with a small envelope of subsidies, which unfortunately is not high enough to really cover all the situations in the priority countries. And health represents roughly 3% of activity. So it's really one of the smallest sectors in which we intervene. We mostly intervene in Western Africa because historically we have links with that region, also in Northern Africa, also in Latin America, Caribbean, Haiti, and also in Southeast Asia. Thank you, Mr. Paquet. Mr. Jeffrey, you work on women's health and children's health, so you spend time to document the daily life of us mothers and children, and also you're an anthropologist, and therefore you tackle the local specificities and what makes those patients different. Can you please explain how you work? Well, that's a work which is complementary to what Mr. Paquet has just described. We started with this beautiful sentence by the WHO. It belongs to Jacques Ellul. So we have to think globally, but act locally. So think globally is not that difficult. You need a few experts in a room and we all agree. But now, how do we work locally? Acting locally is a difficult question. First of all, because there is no theory on how we should act locally, and also all the local definitions are very complex. It's upsetting very quickly. In Africa, there are 800 languages, so we are using translations all the time. The situations are very different. Diseases are very different. The pain of a woman giving birth is not the same pain as someone being sick. It is not the same sort of pain. It doesn't have the same legitimacy. And therefore, we do not want to only start with a program. We need those different variants to be taken into account. They're well described by epidemiologists, but they have to be implemented in real life, and they have to be translated in a series of behaviors. And so we just try to envisage the world from the local sphere. So we want to start with the context, and context basically is real life. So we want to start with life and understand how a series of meaningful objects, of practices, popular practices and professional practices can be brought together to help and solve difficult situations. I've worked in this framework for more than 30 years with teams of epidemiologists on how we can, first of all, create a maternity ward in hospitals, how we can deal with contraception and avoid unwanted pregnancies, which used to send young girls to certain death. And with a number of countries, and for some 40,000 children, we've worked to improve their health with the French embassy and and help from Monaco as well. So what is the situation in the health services in African countries in which you operate? I would like that each of you maybe give me an answer in a few words. So who'd like to have a floor? What is the situation, the health situation in your countries? So you have a microphone, so you'll talk first. Well, 30 seconds. I'm going to read something that anthropologists have observed, and I'm not going to cite the country I'm talking about with this quote, but it's just to illustrate how difficult it is to switch from those programs, global programs, to local. 11:50, Kakiatu, a girl 6 years of age, needs care. 1 hour later, the nurse is taking all the drugs out of the cabinet and asks the mother to hold the child. 12:10, the mother places her hand on the chest of her daughter. The nurse is inserting the drug in the catheter. Katiatu is crying, she's panicked, and you can tell she is in pain. The nurse realizes that the product is blocked in the catheter because the vein has been perfored, has been cut. So we need to insert a catheter on another vein on another limb of your child. The nurse is asking, do you have another catheter? There's no catheter in the hospital. They have to go to the pharmacy. I'm switching quickly. Now it's 1:05. Kaliatu is asleep. The nurse is giving a shot to the little girl and she starts crying. And again, she can't get the catheter. She can't get the drug into the body. A more experienced nurse arrives and is giving an extra shot to the child. So this is the sort of observation that we have with a series of pediatrician friends, a group of 50 colleagues, also researchers in social sciences. And basically, this raises the question. This is the implementation science that we're all talking about. So how the decisions that are made at the program level, how do they blend in practice? And we really need to bridge that gap between the theory of a program and real life. So yes, we have to define programs, but also we have to be extra cautious on the way those priorities do blend in real life. And we have a problem because those programs are like water on duck's feather. They roll on top of the feathers, but they don't get inside. So what do you think? Is there a gap between the places where the programs are being developed and the implementation in the field? Well, that's obvious. And it's a bit easy to phrase the question that way. But according to me, the best indicator of the quality of care is the number of people that go to those institutions. Many people in this room travel different places, not only to Africa, and in many countries where access to care is said to be difficult, you may think that those infrastructures are full and overloaded, but most of the time when I go to dispensaries or hospitals, they are empty. And when I visit hospitals that are empty. And the underlying problem is the problem of quality. Now, how is the lack or the need of care is going to be translated, where it may be a problem of human resources, of drugs, a problem of lack of finance in countries, and we mentioned that already. People live with a few dollars per day, and so when you have to pay some $200 to get a C-section, this is of course not affordable for many families. So the lack of quality is going to be measured in a different way, but clearly I think one of the indicators is the number of people that go to those hospitals. Well, if you agree, Christophe, you sent a video, and this video demonstrates how we can participate to improving the quality of life. This is with the Medical Credit Fund in Tanzania. So we're going to watch the video and then we shall comment it later.
This is Mission Bagala Dispensary. We are located 10 kilometers from the city center. It has been difficult for us to obtain a loan because we don't have collateral. When you have at least put something else for you to get a loan. Then if, well, can you place a microscope so that to get a loan? It's difficult.
In Tanzania, there are many patients who spend all their life till they die without seeing a qualified medical doctor or being attended in a facility that cares about quality. The Medical Credit Fund has got a very important two components. One of it is providing business education for the private healthcare providers so they can manage the business from a business point of view and not just a social venture. And number two is looking at improving the quality.
Our plan to improve our infrastructure, the first thing we have to do, we have to improve the pharmacy area here. We'd like to put an air-conditioned here so that at least we have a safer place for our drugs for the patients to receive. Thereafter, this is a very small laboratory. It doesn't cater for the services we intend to give. We want to expand to have more space in the laboratory. So we have to break this part of the wall here so that we can create more space for the laboratory.
So the Medical Credit Fund is now trying to work into trying to shape the quality structure and trying to see that the standards that are reached, they can be minimum standards, but at least we can grade them and so that the facility will always look higher at achieving higher and higher standard and having a goal to attain.
We are happy that this medical credit fund has come up. At least it has come up to, it has been, we expect that to be a remedy for us, even a remedy for the clients we are serving, the community we are serving around.
So you see that the funds are being used to install an air conditioner, to break a wall, to have a bigger lab. It sounds obvious when you want to improve the quality of care in such a hospital. Is it always that easy and so easy to objectify, to define the quality of healthcare? Well, if I understand properly from the video, it's an interesting initiative in that it addresses two challenges of private structures, because the private sector does have a role to play when it comes to universal healthcare coverage. Its first mission is access to loan for the small structures, which most of the time do not have access to bank loans. So this is one of the prongs of this initiative. And the second prong is supported by Farm Access, an NGO from the Netherlands. And so the other prong has to do with improving the quality of healthcare. But it has to do with the infrastructures, but also training of healthcare professionals. And once those private structures have benefited from the health of the credit fund, they become certified. They receive the MCF credentials, as it were, or certification. And I think it's important. It's important. It's a good way to tackle quality, especially from the point of view of healthcare professionals, which certainly is not always my point of view, nor the point of view of my colleagues here, not the point of view of patients for that matter.
Or what you might call a very scientific approach to define quality in healthcare services. It's a step-by-step accreditation process. Can you tell us more about that? Can you explain?
Well, we have faced similar challenges with regard to improving access to services in Rwanda. And as my colleague said, that quality indicator can be measured by access to services. We reached an extent where access to services going to the facilities was not enough, but looking at how safe these facilities are, because it doesn't make sense to sensitize women to go and deliver from hospitals, and yet those hospitals are not safe. So we have packaged together quality and safety to really have a comprehensive approach to quality improvement through setting standards and introducing a national accreditation system. When people talk about accreditation, it's like, no, we are not yet there, especially with our countries with limited resources. But what I want to tell you, as the video was telling us there, you start small and grow big. Start with the basic standards, and with the in-depth, improve the standards step by step. So we took a stepwise approach of increasing the quality of services in all health facilities, starting with the 43 district hospitals. Then we are planning further to include the health centers. The stepwise approach is like set standards, basic standards. With time, as people implement them and really work towards the standards, you start adding more standards depending on the national priority.
Just a quick word. What do you mean exactly by basic standards? Because that can have a very different definition from one place to another, actually.
Okay. When I say basic standards, we start with the infrastructure. Infrastructure basic standards looking at stable water, stable running water, electricity that is really in our countries, we have electricity that is not consistent. Then plan the backups so that whenever electricity goes, you have electricity when a mother is delivering, because these have caused a lot of problems. when I talk of basic standards, hand hygiene. Hand hygiene is something small that we talk about, but without hand hygiene, we've had a lot of issues. Surgical site infections. A mother coming to the hospital who is supposed to spend 3 days after post-cesarean section and spends more than 2 weeks. That's an additional expenditure. And really, looking at those small things, you make a very big difference. And further to that, even the infrastructure that are existing, given the old ones and the new ones, we did some rapid assessment, and they all have similar challenges. Similar challenges just because from the concept of thinking of these health structures, safety is not thought at the beginning. So we are like, let's see even how we can guide people that work on the architectural design of health facilities to consider patient safety right at the beginning, at the concept of really working out these designs. So those are the basic things I was talking about. There is a lot. Environment, safe environment. Safe environment for both patients and staff. Accountability for the leadership of health hospitals. So we have set standards in those different areas. Infection prevention and control, those are basics, but they make a very big difference. And with that, when you talk of accreditation, people think we have to talk of the international organizations that are experts in accreditation. In Rwanda, we have adapted it to have a national system that is country-owned and managed at the country level. At the country level, we still have a challenge of really this is being done by the Ministry of Health and the supporting partners, but to avoid conflict of interest as things grow, we are looking around at having our own accreditation body. Even those international accreditation bodies, they start small and grow big. So we have looking at initiating our own accreditation body that is affordable. Affordability is very, very important because relying on external organizations is very expensive and not sustainable in future. So we took that as a comprehensive approach to quality improvement, given the pretty good of the approach, because it has helped us to look into all services, a range of services.
So I think it might be interesting to give the audience an idea of how this implementation process plays out on the field. We have a video that you send us on the work MSH is doing on the field, and I chose the following extract, so just to give you some information before we listen to it. This is where the director of the Kibongo Hospital in Rwanda discusses how the accreditation process eventually led to a surge in the number of patients who visit the facility, and he also talks about his heightened sense of pride in his work. So listen closely because some sentences might be difficult to catch.
We entered the process of accreditation. Then accreditation improved our quality of services that we offer to our patients. Then if you consider the satisfaction of the patients now, saying that the people are now knowing that the Kibungo Hospital exists and it can offer good services to the population, whereby the people from different districts, the districts that are neighboring us, if they know that our services are of good quality, then they come here. Directors from other hospitals, they are coming to learn from our hospital. We are going there to teach them how to offer these medical services. If you see that you've just decreased the neonatal mortality, if you see that you've decreased the maternal mortality, then you become proud of that. So being a director of this hospital, in fact, I'm very proud of it.
Okay, perhaps just a quick reaction on this, Joy.
Thank you for that short video.
Mm.
When the video was on, there was a graph of reducing patient waiting time. Patient waiting time. Of course, with the insurances, the community health insurance and all that, Rwanda has managed at least to improve access to services and reducing financial hardships to the population. But again, even when you have the card to go to access the services in the health facilities, some of them are found on these big long queues, and they end up going back without accessing services, and yet they have the right to access the services because of long waiting times. So Chibungo Hospital was one of the hospitals that really worked on the client flow analysis, analyzing the flow of patients in the hospitals, identifying some bottlenecks, and working towards reducing them so that they reduced their waiting time from 7-8 hours to 3.5 hours. So this is something very good that really, when I talk of simple things making a very big difference, I refer to that. So the reduction of neonatal mortality rate, the reduction of maternal mortality rate, all these have been directed by the setting of standards with those very services, and the professionals have been motivated, because when we talk of quality, we need to define it, and we have been able to define it through setting standards and introducing that accreditation. As you saw, that the director of one of our hospitals was like proud of it, and it has contributed to the increase of internal revenues of the health facilities, and Chibungo was one of those hospitals that benefited from that.
Thank you, Joy. Je me tourne vers vous, Yannick.
I'm turning to you, Yannick. You were saying that you do not believe in implementation science, the Anglo-Saxon word. That would be science for which you implement programs. However, it seems to work out fine for that program. Well, I was not saying that I was against it. I was just sort of criticizing the word, the way that we bundled together works that have existed for many years, because the first works by anthropologists dates back from the 40s. And you know, on a regular basis, you tend to rediscover old things. But again, I was not criticizing those programs at all. Quite on the contrary, there are many programs out there, and that's a good thing. However, my role has to do with analyzing what happens, all the mundane things that happen on a daily basis. And I'm also here to pinpoint what doesn't work properly. For an anthropologist, there is the before, the during, and the after when you go to the hospital. And there are those questions of healthcare training, because when people pay attention, that when they receive care, we don't speak with them, and we speak with them after they received care, when it's sort of too late. So when we look at the rates of a death rate, especially children death rate, we realize that they die in the 24 hours before being born, which means that the representation of health and the power in the family is also important to know, because when the mother is giving birth, sometimes it's the mother-in-law who decides whether they're going to bring the mother to the hospital, or sometimes the father. And then you need the money to purchase drugs, and those drugs are going to be sold in the pharmacy, but sometimes in the pharmacy you receive the good drug, but sometimes you don't. And sometimes they say, well, you have a painkiller which is less expensive than the antibiotic, and then the patient is going to take take the antalgic drug, and of course the effect is not the same. We've recently conducted a study in 5 countries on the first week of life of a child. In Western Africa, almost all children receive a bath after they're born, and the children are neglected for a series of reasons, and so they are in sort of an uncertain space because they are not baptized. The mother's not here, the father's not here, they're not in the obstetrical ward, they're not in the pediatric ward. And so the first concern when they go back home is to get the child baptized. And so you don't really take care of giving them proper baths, or you don't really take care of giving drinking water. So in our jargon, we say that the hospital in Western Africa do not work as an expert system. In the Western world, when we want to send a letter, you don't care about that because you know that the entire system is an expert system. In Africa, especially in the maternity ward, those are not expert systems. There are a lot of inequalities when it comes to health, where you are the spouse of the doctor, or if you know the doctor, you're not going to pay and you're not going to wait. If you are unknown, if you are a nobody, as it were, you're going to wait. If you are fortunate, you may enter. But if you are not fortunate, you may wait for an entire day, have to walk back home and come back the next morning. So Dokotoro is the nurse, but sometimes it's the medical doctor, sometimes it's just an electrician that just provide ophthalmic care of some sort. So there are not enough healthcare professionals. And so if I break a leg, it happened to me in Senegal, and so I called a friend, a neuropsychologist, and he helped me get into the structures because I had this connection. But one of the main problems in Western Africa is that the structures that we have, it's an expert system. We do have a few hospitals where all patients can be treated in the same way, but within that structures, there are many individual structures which make it possible for someone to make a call because there's a friend of a friend that was just were received in the hospital, and basically the system doesn't work the way it should. And so unfortunately, when you're a nobody in such a system, you can die of it. I've seen women with eclampsia die in the corridor because they knew no one. And when you know no one, when you have no existence in such a hospital, you're running a very high risk. And unfortunately, today, and I think this is a program on which a topic on which we need to work, how can we build practices that are equivalent for everybody? And we need really to have a system that is fair for all.
Listening to what he was saying, would you like to react on that?
I appreciate his comments and his experience, and what he's talking about is nothing but the truth. But we need to give guidance to these health professionals, and the guidances are the setting of standards. I'm coming back to standards, the protocols, the guidance, all these are standards at different levels. And with this, then we are ensuring, or we are towards ensuring that most of these services are provided equally if these standards are adopted at all levels of the health system. Because take an example of a mother with preeclampsia that he talked about. That would be through the protocol should be there. How does somebody with preeclampsia, it goes to the hospital right from admission to the discharge, how is this mother going to be managed? So most of these standardizing our practices really would address some inequities in some of our services that we provide. And where back home in Rwanda, it's still a long journey. Quality is a journey of so many steps. but with standardization, with efforts to motivate the health workers. Because we are talking of the numbers, but even motivation is another issue. So we have worked out a model of tying incentives to quality improvement efforts. We had what we call performance-based financing. This was one of the scheme of health financing. And for the last 2 years, we've explored tying incentives of performance health financing to quality improvement efforts. It's a journey, but there are some substantial results.
Let's watch a piece of the documentary that Yannick made on the study of the Inspedia group that was conducted in 9 countries. The aim was to determine how to improve patient care in pediatric wards, which is one of your fields of activities. Let's have a look.
En Afrique, les enfants de moins de 15 ans représentent 43% de la population. Parmi les 10 millions d'enfants qui décèdent dans le monde chaque année, l'Afrique représente pratiquement la moitié de la mortalité des moins de 5 ans et 36% des décès néonatals, alors que le continent africain ne compte que 23% de l'ensemble des naissances. Les principales raisons sont les maladies infectieuses, diarrhée, paludisme, pneumonie et infections respiratoires, le tout aggravé par une situation endémique de malnutrition ainsi que des causes liées aux conditions de vie, accidents de la route, plaies, brûlures, fractures. À cela, il faut ajouter un ensemble de pathologies soit chroniques, soit devenues chroniques suite au progrès de la médecine et à l'amélioration de l'offre de soins. La drépanocytose, l'infection par le HIV, le diabète, les cardiopathies ou certains cancers. Pour ces multiples et diverses raisons, les enfants sont les principaux usagers des services de santé et des hôpitaux. Face à ces mutations sociales et à ces questions sanitaires, si l'on a progressé dans les connaissances cliniques et les études épidémiologiques, force est de constater que l'on ne sait quasiment rien sur la façon dont ces enfants vivent, se représentent et éprouvent parfois douloureusement leur maladie, comprennent les traitements, ressentent les soins, vivent leur handicap. Et pourtant, il suffit d'écouter les enfants pour comprendre qu'ils ont beaucoup de choses à dire et à faire partager sur la maladie, sur leur maladie, sur l'hôpital et sur les soins. Comment leur offrir des soins de qualité sans les écouter et leur donner la parole, sans en faire de véritables acteurs de leur santé ? Par ailleurs, les praticiens, médecins et personnels paramédicaux soignent et vivent chaque jour avec ces jeunes patients. Qu'éprouvent-ils ? Comment font-ils pour trouver la force de soigner malgré parfois le manque de médicaments, la violence des situations qu'ils doivent affronter et les nombreux décès des malades ? On ne peut améliorer les soins sans comprendre les soignants qui les prodiguent chaque jour. C'est à ces deux questions, comment faire pour que les enfants deviennent des acteurs de leur santé et comment aider les soignants dans leurs interactions avec leurs petits malades, que le programme Inspedia, Enfants et soins en pédiatrie, s'est consacré. L'équipe Inspedia comprend autant de chercheurs en sciences sociales que de soignants pédiatres, hématologues, cancérologues et personnels infirmiers. Ensemble, de façon amicale, pluridisciplinaire et dans le respect réciproque de leur discipline, ils ont écouté les enfants, analysé des gestes de soins, tenté d'améliorer des situations de soins et de vie, réfléchi à la mort malheureusement toujours présente et aux soins palliatifs lorsqu'ils deviennent l'unique solution pour affirmer la vie jusqu'au bout. Si les instruments d'analyse sont parfois différents, les buts des anthropologues et des pédiatres sont les mêmes, améliorer concrètement l'offre de soins.
Et voilà, je pensais que c'était intéressant de passer cet extrait parce que
There you go. I thought it would be interesting to actually show this because taking care, including the words of the children in Africa is something that I haven't heard too much. Christophe, is this an important part when it comes to choosing the programs that you're going to be supporting? The obviously taking care of the person who has a disease, including children. I believe that what we just saw is absolutely incredible, and this is probably something that we should work on a lot more. And unfortunately, this is not something that we see too often, whether in Africa or somewhere else. It should be absolutely essential to do this, but it's true that currently, for the financiers, for the donors, the dimension of quality of care, including the perspective of the patient, is often something that we do blindly when it comes to our effort. I would say because, and we saw that, based on what Yannick said, it is something that goes way beyond what a donor, an ONG, or an NGO, or a foreigner could actually do, because it actually brings you back to social and cultural practices that can that have nothing to do with the financial impact. Based on what we just saw and based on what we said, I believe that there are a lot of things that has to do with the motivation of the staff and how human resources are managed. So first of all, it has to do with the governance of the healthcare systems and of hospitals. It is absolutely crucial to strengthen governance, including in Africa. There are very few people who are actually trained to become hospital directors or hospital staff in all directions, and so this is something that we need to focus on as donors. Something else, what we saw about Rwanda, is financing based on performance. That's an approach that is currently championed by the World Bank. It's an ideology model that basically reintroduces money so that the actors of the system can improve their own working conditions and therefore have more people in their clinics or their immunization coverage, and at the same time increase their wages, their own life quality by using part of that money for that. And all of this is supposed to start a virtuous circle. With more people, you have better performance, and therefore there's more money introduced into the system. So this is a system that seems to work pretty well in a country like Rwanda, for instance. Is not like the perfect recipe, and I believe that we can actually come back to this afternoon with Valérie Reet, who's a big expert of the topic. But I believe that this is an example of an action that could change things slightly, including what's crucial for me, meaning staff motivation. Before we close this roundtable, I'd like to summarize pretty much everything that we said. Circling back to the universal health coverage, which is the main topic of today's conference, there are two things that I wanted to talk about. There are many things that are actually done in many countries in order to go against the fact that we don't have too many doctors, which is community health agents. Do you think it's a good or a bad idea? Is it a way to actually provide access to all? Or is it a way to actually pull quality down? Who wants to actually answer that?
We have introduced what we call a community health workers program. These are people that are not professionals in health, but they are people that have self-motivation. They are volunteers at the rural communities. And with this, we have really they are pillars of the health system in Rwanda, in that they are close to the communities. And once I could give an example, like a mother who is going to the hospital to deliver. First, they start with sensitization, sensitizing mothers to deliver to the at the health facilities. That's one. Two, if there's a mother that maybe starts labor in the community before reaching the hospital, the community health workers, they identify those mothers first when they're expecting and when they have problems, maybe starting labor when they're still at the community level. And we have worked out a system to support them. They also need to be supported. We have introduced what we call the rapid SMS. The rapid SMS is that the community health worker has a telephone, and once they identify a mother that needs help, like say breeding, just SMS say breeding mother. Then the message comes automatically to the phone, guiding the community health worker what to do immediately. Same message signal goes to the health center to say, get ready, there's a mother in the nearby that is coming to, that is likely to come to the health facility. Same message goes to the ambulance people that quickly rush to this point. There's a mother that needs transportation to the hospital. So the program has been introduced. Of course, these are not health professionals, but because they are motivated, we are building on the motivation they have. They are volunteers. So we have worked out of some systems to support them so that they can be very useful at the community level. The challenge comes to the quality of services they provide. They need to be supervised, because these are people who are non-professionals. So the closest health center works out a way to organize supervisors for these health communities. But again, somebody who is a volunteer, you can't rely on that person. It's not really a long-term strategy. So you need to keep motivating them. And we have worked out what we call the community health workers cooperatives, putting them into cooperatives so that they are encouraged to do some business, generate some money, so that they earn their own living and they are motivated to keep carrying on the voluntary work. Because this is a big number that you cannot decide on salaries to pay, has a big budgetary implications with limited resources. But at that level, if we are talking of increasing access, even at the lowest level of the community health workers program has worked. Again, there's another initiative still at the community level, maybe that we could share this experience, what we call the community, we call it public-private community partnerships. So there are a lot of health posts coming out, especially where it's far in those isolated communities. So what we are doing is that we are motivating nurses to own those health posts. And the government supports them by giving them a soft loan to operate those health posts. So out of 520 health posts, at least in the first phase, 150 are in that program of public-private community partnerships. So by enforcing those health posts to work and be operated well by the nurses and supported by soft loans, it's like it's a public-private partnership model of you build, you operate, and later after 5 years, you own it. So it's owned by a nurse at that level after 5 years, servicing the loan. Then they keep supporting them and supervising them and see how at the lower level, because we are all concerned of quality of services, not even at the high level. That quality is an issue everywhere, but at that lower level of the community. So those are different initiatives and reforms to see how we can enforce the quality of services at that level.
And I understand that these agents, though they are not health professionals, they're not left all by themselves to cater to the different populations they're sent to. Just one last question, very, very quickly. I don't know if this is something that you thought of, but it crossed my mind while I was preparing for this roundtable. when we speak of UHC, we're essentially speaking of Western medicine, right? So does this mean that having this sort of service available for just about everyone in Africa means the end of traditional medicine? And is this a good thing, if you think about it?
Oh, well, traditional medicine, very important also. So what we have worked with the WHO, World Health Organization, to support the traditional medicine, because if you leave them also on their own, then you have a lot of problems and complications to the system. So engaging, the strategy we've taken is engaging them. The traditional, we have managed to put them into, to request them to go into association. They have their own association and their own umbrella. So with that, you are like putting them together so that it's easy even to know what they are doing, because if you leave them at their own, at the end of the day, you have problems that that you will not be able to manage. So be engaging them in most of the health programs. And at the same time, they have a direct link with the community health workers so that they can work together. They can work together, and because I could give an example, there used to be tendencies of discouraging mothers to go to the hospital by the traditional health workers, by the traditional health healers. But if they work together with the community health workers, then with regard to sensitizing mothers, children to go to the hospitals, you somehow move, you somehow move an extra mile of really not leaving them on their own, but feeling that they're also supported and recognized. They need to be recognized in the system. Yes. They play a big role, and if you're not careful, you end up with problems.
I understand this. Thank you, Joy. Yannick, Christophe, peut-être une réaction très rapidement sur ces...
Thank you very much, Yannick. Reaction on what we just said. What do you think about that? Okay, so first of all, I believe that for an anthropologist working really on the field and for a long time, the issue is to make sure that population with health problems are going to meet healthcare professionals. They have characteristics. They're universal, whether it's in Africa or somewhere else in Europe, it's the same thing. It's a matter of thresholds, it's not a matter of nature per se. And you have healthcare professionals that are in an atrocious situation. They see children and mothers dying, they'd like to do things, they can't. And so these healthcare professionals are in a horrible situation. They're suffering a lot. And I have friends who are approximately my age who say to me, you know, sometimes I go back to my office and I start crying. We need to understand that. And when you have that kind of violence, but the violence against healthcare professionals, they are in what I would call selective ethics, meaning that the rapport between offer and demand means that because you can't do everything for everybody, you do some for some and nothing for a lot of people. It's like in Marseille, I give €1 to one beggar and nothing to another one. It doesn't have much impact as far as I'm concerned, but on the bigger scale, somebody else could die. So there's a huge gap between people with a huge demand and healthcare professionals who see their profession being deconstructed because, for instance, you don't have medical dossiers, you don't have devices like tensiometers or stethoscopes, and so you need to organize all of that. Also, thinking about the populations means thinking about them in a simple way. Let me give you an example. At the beginning of HIV, we had traditional practitioners who were specialists of HIV. They were traditional, they had been professional for 1 year. An anthropologist never talks about tradition. Tradition is basically giving power to the present time. If I say that I'm a modern anthropologist, they're going to say that he has a lot of history. Tradition today is not tradition what it used to be, Africa or somewhere else. Traditions are currently always constantly reinvented by the new generation. And it's not medicine either. Medicine means that you have something written. So in the population, you have some knowledge, partial knowledge, which is sometimes useful. Say a person who's going to help with a strain on your ankle, but it could be atrocious if there's a lesion. Sometimes mothers could actually help when her daughter or daughter-in-law was delivering the baby. But that didn't really mean that you were a practitioner or a traditional practitioner. So that's been questioned. A traditional midwife could basically avoid cutting the cord in a bad way and give the mother tetanus, but at the same time she can't do a lot. And so we need to wonder what she can do in order to remain relevant. And also, we should never talk about community. There are some collectivities with different opinions, and I really worked on all these issues, been working on this for 30 years. Whether you are helping or a sanitation agent or a hygienist, etc., no matter what the terminology, you're going to have a situation that's going to be very complicated. For instance, should they sell drugs to their own family? No, so they never have money in their purse. Should they actually send somebody to a hospital that might not be credible? Will a traditional midwife say to somebody who's delivering the baby, go onto your motorbike and go to the hospital? Obviously not, because what happens if the mother dies when she's on the bike? There's a poet, George Seferis, that said, we have overburdened our field with too many cries. And I believe that in this world of sanitary or health development, we need to go back to simple terms. Very simply, for anthropologists, I don't know what traditional medicine actually is. Christophe. So when it comes to the compatibility between traditional medicine and universal coverage, I don't see any problems in terms of compatibility. In France, you can see an acupuncturist, a homeopath, and that is reimbursed by your private health insurance. So it's not really traditional medicine, but it's non-scientific, non-rational, that we actually decided to include in a reimbursement system. So it's not really a problem of compatibility. Now, when it comes to the question of community health agents, I'm not 100% convinced by that kind of model that we actually promoted in the 70s. This model of an agent coming from the community that could solve all the problems. And Yannick actually reminded us of some of the limits. I believe that there are a lot of things that need to be done in terms of delegation of the tasks. We could train some doctors who are not surgeons, but we can teach them to do a cesarean. We could actually train some prescribers. After 2 to 3 years, they can actually help with prescribing drugs in some clinics. You can see that in Eastern Africa, in Costa Rica. It's very difficult in Western Africa because they have a traditional French culture, which means that you need a doctor with a diploma. If you don't have a diploma or a degree, you're not a doctor. So you need to improve access to care, but there are a way to actually improve the access of these practitioners to a number of things. Thank you very much. To all of you, I'm going to turn to you in the audience to see if you have any questions for one of the actors. I believe that there's a mic, and I believe there is someone who's requesting to ask a question. François Richard, I'm a doctor. 2 very quick questions regarding the quality of the offer. In order to implement health systems, international organizations and the donors recruit the best healthcare providers, midwives, doctors, etc., to include them in the system. They completely take them out of the actual system, so how can you improve the healthcare systems by acting this way? Second, August 30th in Zimbabwe, the African Union decided to recruit 2 million of community healthcare providers. As you said, we need to motivate them. So how do African countries fund these people and at the same time fund the universal coverage? Very good questions. I believe, Christophe, the first question is for you. Obviously, it's the brain drain question, which is not due only by international programs. It's also due to the fact that we don't have enough doctors and healthcare professionals in northern countries. That means that a number of people from southern countries come to work in our countries because they have better living conditions and they find a number of conditions that are much better for them. In terms of the programs and the donors, as far as we're concerned, we work mostly with a Ministry of Health most of the time, and we try to make sure that our program is going to reinforce, strengthen the Ministry of Health. So that means that we give or loan money to a Ministry of Health that's going to implement the program with their own means, their own staff, their own resources. And as part of the program, we have a capability strengthening module, but donors like AFD are not substitution NGOs that are going to take staff away from somebody else to do whatever they want on the field. And regarding the second question that the gentleman asked, regarding the motivation of these community people who are not healthcare professionals, is it difficult to find the money to do that and also to fund the coverage at the same time? Maybe, ma'am, you have an answer to this.
Of course, when it comes to community health workers, it becomes very difficult to fund because it's a mass of these people. There are many. They are everywhere. They are the lower levels of the community. And looking at the sustainability and relying on external funding is also another challenge. And that's why there has been an option of looking around the internal generated resources through their cooperatives, supporting their cooperatives so that they can get money and they earn their living, and it keeps them motivated to really give a voluntary service. I still call it voluntary because they are not paid salaries, and they have to generate their own incomes with the support, of course, of the government, so that they can remain playing that crucial part in the health sector at the lower level.
Une autre question de la salle? Oui.
Do we have another question right here? Thank you very much. We're listening to you, sir. It's also regarding the healthcare professional and staff and the possibility, with all the gaps that we've seen that are tragic in terms of care offer, to actually delegate the care and create pathways to degrees, diplomas, so that they be recognized by the community and the professionals. In order to attract these people to improve their own social conditions by having the possibility to get a diploma in order to then improve their own care offer. This is doable. And Christophe, you actually said that we obviously have problems in terms of acceptation. I would say that some more francophone groups, more than anglophone groups, will probably be able to benefit this kind of approach a lot better. did you want to actually provide an answer? Yeah, I wanted to come back to this issue of healthcare professionals. These people have specific skills, but also a social identity. In some cases, social identity is contradictory to the offers that we give them. Let me give you an example. Since 1945, we try to have midwives available, but a midwife is midwives available in the suburbs. Sometimes they're not married, so when they go to the suburbs, they are sometimes hit on, or the prefect is going to want to do something to them, and ultimately when they come back to the capital city, they sometimes have realized that the husband actually found another wife or whatever. So we have health proposals that are completely in contradiction with the social identity, as Christophe actually said. Since the 40s, we've been trying to implement the same programs over and over again, and it's not working. Maybe we should actually try to make sure that maybe some nurses or doctors can actually do deliveries and cesareans. Sometimes we need to realize, and C-sections, sometimes we need to realize that some programs can be implemented, but the staff is always going to be there. And the staff that we're talking to, that's people that actually knew primary care and health for all in 2000, free care, etc., etc. These are people who have the memory of all our huge journeys. And what do they do with all of that? What do they believe in? What do they do with all of this? And number 3 is that hospitals in Africa are full of volunteers, because when you're a volunteer, the number one thing that you do is you get money, because when you're a volunteer in a healthcare system, you're going to try to have a little bit of money. You know, people are going to say, well, you know what? I know the doctor. If you give me 500 French francs, I'll take you to the doctor. So as soon as these people are a community health care person, they actually want to actually be part of the official system and be paid like an actual nurse by the government. And you know what? When they see that somebody's doing an injection, I mean, it's not that difficult. And then after that kind of thing, then you actually do something more difficult. And little by little, you see that professionals are slowly improving, but ultimately the skills do not match the actual facts. So ultimately you need to pay attention to the words that you ultimately use. And I'll come back to the brain drain, as we said earlier, by international organizations. It's not just that the good skilled workers are a victim of diaspora. I have a good friend who used to work in Bobo Dioulasso. Now he's in Baltimore at Johns Hopkins, because now he's working for an American university. We all have African friends who, and thank God for them, because their salary was multiplied by 10, especially obstetricians. They're the kings of public health. And ultimately, that's a bit of an issue. And I remember that a few years ago, I believe that IRD created southern internships, saying if you work well, we'll give you some money to actually do some research in your department. And I believe that maybe this is a motivation in a very simple way, saying, okay, you're going to do your job, then you're going to be paid to do some research. If you don't do this, you won't get any money. Quite often, I don't really understand why with Africa we're using such a complicated terminology. It's just the exact same thing as in France or in the US. You can delegate some tasks, you can actually improve the skills of people who are doing a lot of things. If you're working well, you're gonna be gaining more, earning more money. You can actually think that in Africa, just like everywhere else, if people have money, it's because they're doing a good job. it's not any different from anywhere else. Very good point. A reaction possibly on training leading to a degree or a diploma? Is it something that is potentially doable to make sure that those healthcare people are going to get the skills necessary and the diplomas to get part of the official system? Yeah, but then it's all a matter of the recognition of the training. The training needs to end up with a degree. It needs to have something they correspond to in terms of wages as part of the official system. Based on all these discussions, what we see is ultimately that when we're talking about the quality of care and the implementation of UHC, it all comes back to the human element. It is the key part that means that whether or not we're going to manage in a country to implement universal healthcare. And ultimately, that's what's most important. Thank you very much. Let's give them a big round of applause.